We are bypassing the pleasantries and jumping straight into the clinical material today. This explainer covers lethal valvular emergencies. We're analyzing rapid, catastrophic hemodynamic shifts where standard medical algorithms fail and compensatory mechanisms completely collapse. Our goal is absolute, peer-to-peer mastery of these discrete mechanical complications, and specifically the exact management traps that define these crises.
Take a look right here at this ECG. You're seeing ST segment elevations in the inferior leads, 2, 3, and AVF. This is a definitive acute inferior myocardial infarction. Now, the critical downstream mechanical complication we have to anticipate involves the posteromedial papillary muscle. Why? Because this muscle relies on a single blood supply, almost always the right coronary artery. If that vessel occludes during an inferior MI, the ischemic papillary muscle can simply rupture. And when it ruptures, it immediately detaches the chordae tendineae. This abruptly causes acute, severe mitral regurgitation, driving a sudden and massive influx of blood backward into the pulmonary circulation. The immediate result is rapid, profound pulmonary edema.
And this perfectly illustrates the hemodynamic equalization trap. To catch this acute emergency, you literally have to unlearn the chronic presentation. Think about it. In chronic mitral regurgitation, the left atrium has time to dilate. It becomes compliant, right? It accommodates that regurgitant volume, which gives you that classic, loud, holosystolic murmur. But in acute MR, you have a normal, non-compliant left atrium that cannot expand. Because of that, left atrial pressure skyrockets instantly, and it rapidly equalizes with the left ventricular pressure right in mid-systole. That equalization abruptly cuts off the regurgitant flow early. So, acute severe MR frequently presents with a deceptively soft, short, early systolic murmur, even while your patient is crashing into catastrophic cardiogenic shock. Bottom line, do not let a soft murmur fool you here. Which leads us directly into an absolute pharmacological trap. In the setting of acute mitral regurgitation, beta blockers are strictly contraindicated. If you slow the heart rate, you are prolonging the duration of systole. That gives the left ventricle more time to eject blood backward into that stiff, non-compliant left atrium. You will directly exacerbate the pulmonary edema and accelerate the patient's clinical collapse. Management here strictly mandates afterload reduction instead, like nitroprusside, or an intra-aortic balloon pump to promote forward flow. Let's put this to the test with our first integrated assessment. You've got a patient 4 days post-inferior MI who suddenly develops acute hypoxemia, bilateral crackles, and a soft apical murmur. You need to immediately recognize this as acute mitral regurgitation secondary to papillary muscle rupture. The timing, a few days post-infarct, is classic, and that soft murmur is the exact equalization trap we just broke down. So what is the precise next best step in management? Let's exhaustively dismantle the incorrect options here. Option A, a beta blocker, is absolutely lethal. As we just established, slowing the heart rate prolongs systole, throws more regurgitant volume backward, and actively worsens the cardiogenic shock. Option C, amiodarone, targets arrhythmias, but an arrhythmia isn't the primary mechanical driver of this hypoxemia. Option D, a calcium channel blocker, acts as a negative inotrope and chronotrope that will acutely crash their blood pressure and worsen the edema. Option E, digoxin, is far too slow to act in an emergency and does literally nothing to fix the massive afterload crisis. That isolates option B, nitroprusside, as the definitive correct choice. It's a potent vasodilator. It immediately reduces afterload, dropping the resistance to forward systemic flow, which intrinsically reduces the amount of regurgitant volume being forced backward into the lungs. Let's shift gears now to another mechanism of valvular destruction, acute aortic regurgitation. We're talking about catastrophic drivers here, like infective endocarditis physically destroying the valve leaflets, or an acute ascending aortic dissection extending down into the aortic root and tearing the valve commissures apart. We need to map the exact pathophysiology of an unadapted, normal-sized left ventricle that is suddenly hit with a massive regurgitant volume load during diastole. This brings us to the pulse pressure paradox. Chronic aortic regurgitation is famous for a markedly widened pulse pressure and those bounding water hammer pulses. That's because the left ventricle has had months or even years to undergo compensatory eccentric hypertrophy and dilation. It's adapted to pump a massive stroke volume forward. But in acute AR, the left ventricle is entirely unadapted. It's normal-sized. It simply cannot handle the sudden, massive regurgitant volume. Because of this, forward stroke volume collapses. That classic widened pulse pressure is completely absent. Instead, these patients present with a narrow or normal pulse pressure and profound hypotension.
So you have to understand the discrete management trap here, which is a lethal 4-step cascade. Step 1, you administer a beta blocker. Step 2, the beta blocker slows the heart rate, inherently prolonging diastole. Step 3, because the aortic regurgitation leak happens entirely during diastole, prolonging this phase allows an enormous volume of blood to dump backward into that unadapted left ventricle, causing catastrophic volume overload. And finally, step 4, this massive, rapid rise in left ventricular end diastolic pressure physically forces the mitral valve closed prematurely, completely obliterating whatever forward cardiac output the patient had left. Let's apply this to another high-stakes clinical scenario. You have a patient with a known ascending aortic dissection. They suddenly develop severe dyspnea and a new early diastolic murmur. The dissection has clearly compromised the aortic root, throwing them into acute aortic regurgitation. Their stroke volume is collapsing right in front of you. Which management step is definitively indicated? We must select the intervention that addresses the severe mechanical failure without triggering that lethal cascade. Option A, labetalol, and option B, esmolol, are beta blockers. Yes, they are routinely used to lower shear stress in an isolated aortic dissection. But if acute aortic regurgitation is present, they are absolutely contraindicated because they prolong diastole and cause premature mitral valve closure. Option E, diltiazem, slows the heart rate in a similar way, so it is also lethal here. Option D, nitroglycerin, is a venodilator. It will just drop preload and worsen their already severe hypotension without actually fixing the torn valve. That leaves option C, emergent surgical intervention, as the absolute mandate. The mechanical destruction must be physically repaired in the OR immediately. To permanently lock this in, let's review this clinical variance box. Both acute and chronic aortic regurgitation feature a diastolic murmur. The critical variance lies entirely in the hemodynamics. Chronic AR presents with left ventricular dilation, bounding pulses, and a wide pulse pressure. Acute AR is strictly defined by a normal-sized left ventricle, a narrow or normal pulse pressure, sudden cardiogenic shock, and an absolute lethal intolerance to bradycardia. Let's move into our final module, perivalvular extension. We are mapping the exact anatomical progression of infective endocarditis here. The infection initiates on the aortic valve leaflet. As the destructive process continues, it invades the adjacent tissue, specifically burrowing into the valve annulus. Now, anatomically, the aortic valve annulus sits directly adjacent to the atrioventricular node and the bundle of His. That physical proximity is absolutely critical for diagnosis, because it creates an explicit electrocardiographic red flag. If you have a patient with native valve endocarditis and they suddenly develop a new AV conduction block on telemetry, it is not just some random benign arrhythmia. It definitively indicates that the infection has burrowed straight through the valvular annulus and is physically destroying those adjacent conduction pathways. A new AV block in a patient with endocarditis unequivocally equals a destructive perivalvular abscess. Here is our final integrated assessment. An IV drug user presents with a fever, an early diastolic murmur, and the telemetry shows a new onset second-degree AV block. Now, intravenous drug use commonly causes right-sided endocarditis, but that early diastolic murmur specifically localizes the lesion to the aortic valve on the left side. Given this, what is the most likely pathological finding driving this exact clinical triad? We're going to execute precise mechanism-based rejections for these choices. Option A, septic embolization, is a major complication of endocarditis, but it seeds distal vascular beds, think splinter hemorrhages or strokes. It does not cause an AV conduction block. Option C, myocardial infarction, is highly unlikely to be the primary driver of a new AV block in a febrile IV drug user presenting with a new murmur. Option D, pericardial effusion, could eventually cause tamponade with muffled heart sounds and hypotension, but it doesn't directly interrupt the AV node. Option E, tricuspid valve prolapse, is a right-sided issue and causes a hollow systolic murmur, which directly contradicts our early diastolic exam finding. That means option B, perivalvular abscess, is the only correct mechanism. The infection has anatomically extended from the aortic root directly into the AV node. Ultimately, this presentation creates an absolute surgical mandate. The sheer presence of an AV block in the setting of endocarditis immediately escalates your management. Isolated intravenous antibiotic therapy is no longer sufficient. This level of anatomical destruction requires emergent aortic valve replacement surgery to debride the abscess and restore hemodynamics. We terminate the simulation here.